Dialogues. I am Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases. And my topic for today is Alagille Syndrome. Now, to help us understand this in a little bit of detail, we have with us today Dr. K. Chandrakant, who's a consultant gastroenterologist at Fortis Hospital, CG Road, Bangalore. Dr. Chandrakant is a highly qualified medical professional with a diverse range of specialized training in the field of medicine. He completed his MBBS from Guntur Medical College, followed by postgraduate degree in MD General Medicine from YSRUHS. Dr. Chandrakant furthered his expertise with a DRNB in medical gastroenterology from AIG Hyderabad. Now, additionally, he also pursued a fellowship in advanced endoscopy, enhancing his skills and knowledge in this specialized area. He also served as a senior resident in medicine at SVIMS, followed by a role as an assistant professor in the same department. Subsequently, he continued his career as a senior resident in AIG Hyderabad before transitioning to the consultant position at Aryavat Hospitals in Meerut. Now, currently, he holds the esteemed position of consultant gastroenterologist at Nagarjuna Hospital in Vijayawada, where he continues to provide exemplary medical services to his patients, demonstrating his commitment to excellence in the field of gastroenterology. And he's also associated with Fortis Hospital, Bangalore. Now, the areas of expertise, he done more than 20,000 endoscopy and colonoscopy procedures and more than 500 ERCPs. So, welcome to Medical Dialogue, sir. It's really a privilege to be having you on board here with us today.
Hello, Dr. Nandita Mohan. It is very nice to join this Medical Dialogues, and I'm very glad to attend this meeting to share my insights about rare syndrome of Alagille Syndrome. So, and thank you for having me here today.
Great. So, Dr. Chandrakant, over to you. If you can just explain to our viewers a little bit in detail about Alagille Syndrome.
Yeah. So basically, we'll try to understand what is Alagille Syndrome, and the following heads we'll discuss these things, the symptoms and diagnosis. And though the disease affects cardiac patients, it also affects mainly liver and GI problems as well. So we concentrate on these things as well in these things, and then we'll focus on the management and treatment options. And what is the current research updates, and what are the achievements in the medical fraternity is going to ease out the disease for the people who are really suffering out there. And because this disease is always fraught with liver transplant. So now we'll know about what is this Alagille syndrome. Yeah, this syndrome is like this is multi-system disorder. That means it affects multiple systems, not just one system. It mainly affects liver, also heart, causing a hole in the heart, what we call BSD, ASD. And it also, not only that, it also damages the kidneys, like renal tubular acidosis. And it is one of the rare syndrome. And the incidence of the disease is it is found nearly 1 in 50,000 populations. It's very rare, and sometimes it is seen 1 in 30,000 people. They will diagnose by molecular genetic testing, and there is a variability of the expression of the genotype. So basically, it affects multi-system disorders. If we see this diagram, what you can observe is that these are taken from a journal. You see the blue thing here. The blue thing is a hepatic vein. This is a section of the liver, and the red one is a hepatic artery. That is blood supply to the liver. So the blood supply goes to the red hepatic artery and comes out through the hepatic vein. And the green one is the bile duct. The liver produces green secretion called bile, which is very important for digestion of the food substances what we eat, mainly the fat digestion. So if you see here, there is something called jagged and notched. These are the mutations. When these are not mutated, the bile duct is formed in the below picture. However, when there is a mutation, the bile duct is not seen. That means the bile is produced in the liver. However, the bile cannot come into the intestine because of the lack of formation of the biliary tree. Can we move on to the next slide, madam? So, what is the key diagnostic things we have to see about it? What is the genetic causes? As we have discussed in the previous slide, the JAG1 and NOTCH2 mutations, these are the primary mutations which cause the disease. However, there is something called variable expressivity. What is this variable expressivity? That means even if the gene is there in the person, all the persons who are carrying the gene will not have the same clinical features. Some people will have very mild clinical features, some other people will have wide clinical features. So this is called variable expressivity. That means some people might have just a facial abnormalities, that's it, and whereas some people may have cardiac problems, renal problems, liver failure. Such things can be seen in other people. So that is variable expressivity. Variable expressivity. This is very important. Variable expressivity is the thing. So now the disease is the autosomal dominant inheritance. What is autosomal dominant inheritance? Autosomal dominant inheritance is something that the gene is transferred from parent to offsprings. When the gene is transferred from parent to offsprings, there is a 50% chance that the children are going to carry the genes in autosomal dominant. That means, so 50% of the children will be carrying the genes. And if you see the genes, 60% of them, they do not have to have. That means if you take 10 people, 4% of the people will have a family history of this disease. They may not be having all the clinical features. They might be having a mild clinical features. That is one thing. And the other thing is that 60%, that is 6 out of the 10 people, they will have normal parents, and the parents also don't have any gene, but they will have a disease. That is called de novo mutation. That is, at birth they don't have any mutation, but they have a functional mutation they acquire after birth. But now, so we have something called germline mosaicism also. That means the parent may have 2 or 3 genes, sets of genes in the body as well. So that is also called germline mosaicism. So that can also be there. And in case of history of affected family member, if the family member is affected, then we can do a pre-implantation and prenatal diagnostic test. So basically what I meant to say is here is, if you see here, JAK1 mutation and Notch2 mutation, these are the mutations which are responsible for the development of the bile duct, the biliary tree in the liver, the skeletal abnormalities they will have, butterfly vertebrae, and they can have hole in the heart. This is called cardiac abnormalities, and they can have kidney involvement. If you see this child, the child is having a pointed chin, and the hair is less, and the frontal bossing is seen. There is an increase in gap between the eyelids. Is called hypertelorism and united kidneys. Basically, this is a gene mutation which is responsible for Alagille syndrome. Can we move on to next slide, madam? So what are the symptoms in the liver? In the liver, they can have jaundice, that is yellowish discoloration of the eyes, itching, generalized fatigue, loss of appetite, loss of weight, stomach will be bloated and distended, and liver may be enlarged, spleen may be enlarged. There is swelling of the lower limbs, and they can have altered sensorium. All these are happening because of the problems in the liver. Initially, they will have mild problems, but over time, the liver gets really damaged, and if not diagnosed, they will land in irreversible liver damage as well as kidney damage, which requires a liver transplantation. So basically, it is diagnosed as early as 3 months of age of the infant. Infant is basically the baby less than 1 year of age is infant. It will be diagnosed as early as less than 3 months. So with the genomic testing or exome sequencing testing. In case a family member is affected, then we can do a prenatal testing also. That means before even conceiving, the parents can be tested for the genes, so that the child should not suffer once he is born. So the severe disease, however, can never be predicted. So, so how does it affect the liver? Basically, what we have to see is uh, the normal bile acids. We have something called bile acids in the bile. Bile acids in the bile. These are the very important constituents. The function of bile acids is digestion of the food. So what is going to happen is when the bile acids accumulate in the liver, they damage the liver cells. So it is like the bile salt is produced. The bile salt is made from bile acid. Okay, so bile acid or bile salts, though it is produced by the liver, if it is not going down into the intestine, then what is going to happen is it is going to damage the liver. So liver will die. Because of that, uh, irreversible liver damage can happen, which can be seen in up to 50% of the children, and they will require transplant in the first 5 years of life. Having transplant in first 5 years of life is a very difficult situation. So that is what we have to be concerned about. So when the toxic bile acids will damage the mitochondria and it will damage the liver. So it's going to be a irreversible liver damage for the patients. Can we go on to next slide, madam? See, how does malabsorption of fat occur in this case? Is basically the bile acids will give rise to bile salts, and bile salts are responsible for emulsification of the fats as well as fat soluble vitamins. Because of that, the fats as well as fat soluble vitamins will not be absorbed. So these are A, D, E, and K. They have symptoms of night blindness, vision problems because of vitamin A deficiency, and vitamin D deficiency will cause bone weakness, bone pains, hypocalcemia, tetany. Vitamin E deficiency will cause skin problems, and vitamin K deficiency can cause bleeding problems. And then it is how the treatment goes. Now coming to the what is the medical biliary diversion. So if you see in this diagram, the bile acids will be produced in the liver, and that will go down the biliary tree into the small bowel. And after small bowel, when it reaches the terminal ileum, there we have a ileal bile acid transporter. Ileal bile acid transporter. Here, again, the bile acid will be absorbed and it goes into the blood and it circulates. And this is called enterohepatic circulation. So if we can block here, the bile salts will not be absorbed and they will go in the urine. The excess of bile salts will cause itching or severe pruritus. That is a medical term for itching. So what are the currently available treatment options are? As we have discussed, the ileal bile acid transport inhibitors, they not only improve the quality of life, functioning of the liver, and also they prolong the time for liver transplant, and also they helped in the child proper growth and also good scholastic performance of the child. FDA has approved two bile acid transport inhibitors, which are maralixibat, which is available in India as well, which is prescribed for child more than 3 months old, and also odevixibat. Odevixibat also, it is also recommended about 12 months of the age. We also have a lot of research coming up in NOT signaling and antisense oligonucleotide, where it's like a tailor. They will cut the cloths, like how the tailor cuts the cloths and decrease the size of the waist and all. These ASOs can splice up the abnormal gene and we can put the proper gene. And we also have a NORA1 signaling coming up, which are the new therapeutic modality. So when is the patient considered for the liver transplant? Rather than that, nearly 24% of the patients, 24%, that means you can say quarter of the patients can survive to become adults by 20 years of age. That means 75% of the patients that require liver transplant below 5 years. So though the bile acids, as we said, they are toxic, slowly the liver damage occurs, and if the liver becomes hardened and becomes nodular, called cirrhosis, which is when we calculate a score called MELD score, which is very well approved score, model for end stage liver disease. If it is more than 16, he has to go for liver transplant. Not only that, if there is cholestasis, that is, the bile acids are high in the blood, there is severe itching, the child is not able to grow or perform better in the school, if there are bone fractures, then also we have to go for a liver transplant. However, the survival of the liver transplant patient is very good. Almost it is like 80% survival in the next coming 5 years. So, what is the role of UDCA? What is UDCA? UDCA is ursodeoxycholic acid, which is a synthetic bile acid which was man-made. It is called Udiliv by the common brand name. We give it in a dose of 13 to 15 milligrams per kg body weight. Basically, the bile acids which are produced by the liver, if they are not secreted into the intestine for digestion and absorption, they get accumulated in the liver and they cause necrosis and apoptosis. That means death of the liver cell, and also because of that the liver will be damaged. So basically this bile acid UDCA is a hydrophilic bile acid which when given in these proper dosages will decreases the amount of toxic bile acids so that the liver damage can be prevented. So that is the mechanism. So what are the existing therapies for that? If you can see, the small pouch is created surgically and the bile can be diverted outside. This is partial external biliary diversion. And though this therapy, like external biliary diversion, is fraught with many side effects, that even if when it is done, there is not much improvement in the children and still they are going for a liver transplant. So that is why we have a new drug therapies which are coming, which is called IBAT inhibitors, which decreases the enterohepatic circulation of the bile acids. That means the amount of bile acid in the body pool is going to be down, so as a result the toxic effects of bile acids on the liver will be less and the liver damage progression will be controlled and transplant can be prevented, can be prolonged. So these are the surgical therapies available. Liver transplant is of course the extreme end of the spectrum, very costly and very difficult for children less than 5 years. However, in advanced liver disease, that's the only treatment which is very promising and helping the child to recover to normalcy and lead a normal human life. However, the partial external biliary diversion, as we have discussed, is also there, and we also have the IBAT inhibitors like Meralixibat and Odevixibat, and we also have the potential means they're not in the trials as of now. I'm checking out the literature as of this. There are not actual trials going in humans. They are targeting this in animal models and nude mouse models, which are like DNA sensing and cutting. They'll basically cut the abnormal area and stitch the DNA so that the abnormal protein will be removed. And we have a cold virus called adenovirus. The adenovirus, the abnormal gene will be replaced with a normal gene, and it will be given through the nose, and it will go into the body and it will go into the nucleus of the cell and it will replace the abnormal gene with the normal gene. So we don't have this problem. This is also a potential promising therapeutic modality as of now, but not yet in clinical human trials. So adeno-associated virus is already proven for retinal dystrophy. The retina is a part of the eye where we receive the light signals and we form the vision or the image of the picture what we are seeing, so that we make sense of what we are seeing. And spinal muscular atrophy is the vertebra, the back, we have a lot of muscles around it. They will become atrophied. It has already proven and given promising results in these two conditions, and we are hoping that this adeno-associated virus therapy is also going to help in this Alagille syndrome. If you can see here, I wantedly kept this. This is from a latest journal article. If you see, let's suppose the exon 3, the third one, exon 1, 2, 3. It is a mutant, that is abnormal protein, that is a dangerous or deleterious protein. It is restored, partially restored by splicing and switching or stitching together, or we can edit the RNA bases so that the new protein is completely restored. So these are the mechanisms. These are basically gene therapies. And also we have adeno-associated virus therapies where we can incorporate the proper genes in the abnormal gene so that the proper protein will be produced. These are promising newer therapies which are coming up, which are not of prime time as of now, but they are in the clinical trials and the pipeline, and they are going to hit the market in the coming soon. As of now, what is the future hope? Now we have a study coming in Hepatology Journal 2023 December 1, and what it says is that the Meralixi they have used for almost 6 years right now from the FDA approval, and what it shows is that there is a good improvement in the itching. That means the bile acids are coming down, and also there is low bilirubin and bile acid levels, and there also the liver stiffness is also less when they have checked with the fibroscan, and also the requirement of transplant is coming down in this 6 years cohort of the children they have studied. So it is promising in preventing the transplantation or postponing the transplantation. Livmarli, which is the Indian, which is available, made from the Miram Pharmaceuticals, which is available in India, and this can be prescribed for the patient. And this Meralixi, so costly, it can prevent the progression of the liver fibrosis and prevents liver transplant. And we also have real world experience with Meralixi, and this is also from the Hepatology Journal. If you see the results section, what they have found out is those patients who are having excess pruritus and aged more than 3 months, they have done an iconic trial. The name of the trial is iconic trial, and what they found is that the pruritus has considerably came down along with the bile acids. The liver enzymes were also came down. This liver stiffness also came down. Bilirubin is increased. It's a very well tolerated than previously thought. It's a promising therapy for the patients as well. Meralixi. See, this Odivixi is also available in India. This is the I've intentionally copied this and pasted here, so we can have a small oral pellets depending upon the weight of the child, less than 19.5 or more than 19.5 kilos. The recommended dose is 40 micrograms per kg, and this is the drug. So this is the drug which is available in Indian market as of now. And I'm happy that the Indian market has got the drugs which are recently approved by the FDA from the US government. And also, if you see the Odivixi efficiency, and there is other trial, this is also coming from the Hepatology Journal. What they observed is that it improved the pruritus, quality of life, and liver-related outcomes, including absence of liver transplant, surgical biliary diversion, hepatic decompensation, and death. So if you see, there is simply one tablet. If this tablet, though the disease is rare, with proper evaluation and diagnosis, if we can find the disease in the earlier stages with this Odivixi, almost the liver damage is prevented, and so the liver transplantation can be avoided altogether, and the child can become a very happy adult. So that is the beauty of this molecule, which is FDA approved for more than for children, and it has been in the market for more than 3 years. So this decreases the absorption and thereby promotes the loss of bile acids, so liver damage is prevented. So that's the beauty of this. So what I would suggest is the high index of clinical suspicion is of prime time in these cases, because this disease involves causes heart problems like hole in the heart, renal problems like renal tubular acidosis. Not only that, it can also cause pulmonary stenosis. The pulmonary vessels will be constricted. So if any neonate, or the neonate is less than 28 and infant is less than 1 year, if there is any signs of hepatitis, my word for all the pediatricians out there and the gynecologists out there is that if the liver test is showing any abnormality, like the normal liver test or AST or ALT is also called as SGOT, SGPT. So if they are showing any derangements, and if there is any suspicion of neonatal hepatitis, after ruling out the family history and hereditary disorders of liver, and after ruling out hepatitis and hepatitis B and hepatitis C, because these are the most common causes, and also ruling out neonatal sepsis because they can also present like hepatitis. This is, though it is in the last rung of a differential diagnosis, this is one disease which has been enigmatic for almost like 50 years, and now we have come up with a very promising therapy. So just take one tablet a day, and it is going to avoid the liver transplant, and also prevent the liver damage and avoid liver transplant, and so that it makes the family and the children's life very happy. So that's the beauty of these newer therapies. I hope the newer promising more therapies like adeno-associated virus and gene splicing should be available to the common man, so that the costlier therapies can be afforded, and so that this can be done. And prior to that, if there is any suspicion of disease, the pre-genetic prenatal counseling is also very important. And thanks to the entrepreneurs or startups which are coming up these days, they're coming up with like MedGenome, they're providing us very good genomic analysis prenatal screenings. And we still don't know, because see, 40% of that is 4 in 10% of the patients, they're caused by genetic mutations in the family. Still 6 out of the 10 or 60%, they're caused by functional mutation. It means that the gene is normal, but the functioning of the gene is abnormal. Whatever it is, please keep in mind about this rare disorder when you come across, and don't forget to, and don't feel shy, and always feel free to discuss with your doctors, and because it is only the collaborative care that is going to bring justice and Lawrence to the patient down the line. There's no pointing, even if when I have any doubt, I'll be very happy to discuss with any of the pediatric gastroenterologist as well, though my special interest is there in pediatric gastroenterology. So that's what we should keep our minds open, and we have to listen more when it comes to the management of patient. So that's what I want to tell you for today.
Great. Thank you so much, Dr. Chandrakant, for joining us today at Medical Dialogues. It was lovely to be interviewing you here today.
Thank you, madam.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.